We're going to go through the usual format. I actually really can't see half the slide. Okay. We're going to go anatomically. I've tried to organize it in that manner so that it makes sense. So we will start with cellulitis around the eye. Then we'll go to this display is actually doing my head in. Okay, we'll go to the eyelids and the conjunctiva, then the sclera, episclera, anterior chamber. There, we'll go to the lens, and then we'll go inside and the back of the eye, and then the optic nerve. And then a few of you have said that OSCE practice would be more beneficial than SBA practice. So I've included a little section at the end. I had a look on the amnesty for previous year 5 stations, and red eye history tends to come up quite a lot. So I've put some things in there for that. And then we're going to do some spot diagnoses at the end because it's fun. I'll tell you what, I'm going to put a split window on so I can see my presentation. Righto. So let's go on to the first SBA. There's a mix of difficulties as well. There's a lot of greens and then there's some yellows and what have you. I think we've got Isaac on the poll, so you can end it whenever you like, whenever we're slowed down or if everyone's putting the same thing. Okay, do you want to close the poll? Let's see the results. Yeah, okay, so most of you have clocked what I'm getting at. Can you hide the results? Someone put in the chat what the diagnosis is before I show it on the next slide. Cellulitis. Be a bit more specific. Orbital. Yeah, exactly. So that's what I was getting at. So this lad has swelling, redness, edema, and you basically, there's going to be a lot of this in this lecture, is to kind of distinguishing between a less benign and a more benign differential. So you've got orbital cellulitis, which is infection kind of around the back of the eye, and that's really bad, and preseptal, which is less bad. So you want to look out for the red flag signs of diplopia, also pain on eye movement, because I think there's inflammation of the extraocular muscles, and reduced vision. I'm not sure what the mechanism of the reduced vision is, but basically, yeah, you want to look up for like an eye that's bulging out or one that's really painful, double vision, reduced vision. Okay, so same lad again, different question. My display is actually completely messed up. I don't know what's going on there. While you guys are doing that, I'm going to try and figure out how to use this. Okay, I think I've actually fixed it. Yeah, nice. So this is it's a very vanilla SBA, but it's an important one. I think because because it's important, you're likely to have an SBA on it. You can almost diagnose clinically, but you need to get a definitive measure of whether or not there's septal or orbital cellulitis. So yeah, CT orbit, as you all say. Okay, so peri-orbit, key points. You want to differentiate between these two things: preseptal, which is kind of like standard cellulitis, bad, but you're not shitting yourself, versus orbital cellulitis, where you are. They're both redness and swelling, but orbital has reduced vision, double vision, painful eye movements, might have proptosis, basically signs of infection, inflammation behind the eye. You need to do CT orbit, and you'll tell Ophthalmology who will give IV antibiotics. So this is the first of many ophthalmic emergencies that we're going to see today. Move on to a different presentation. Isaac, can you please take control and then let me take it back? I can't see what I'm presenting. It's a bit of a nightmare.
doesn't give me the option to take control Ed for some reason.
Someone else is taking it. Thank you. Then, yeah, this just isn't going to work. I'm kind of like, I'm trying to navigate on the Zoom, on the Teams meeting, but read the slides off my PowerPoint file. I'm not even sure what's going on.
Oh wait, do you want me to take control? I can do it now.
Is that how you did it before?
Yeah, and then I
if
had
you wouldn't
to click
mind
the
that.
slide.
Yeah, I don't know why it's happening again. If you wouldn't mind, that'll make it way easier for me. And then when you want, you can. Oh, sorry.
Really peculiar though, because it all looks fine on mine.
Yeah, I shouldn't have highlighted painless. I don't know why I did that, but can we move to the next slide? So this, yeah, this is again where you want to distinguish between two differentials. So you have eyelid swellings. You have a stye and a chalazion. And so a chalazion is a non-infectious cyst in the eyelid, and the best thing to do is manage conservatively. So you can use hot compress, ensure that the patient follows general hygiene measures, and a lot of them are self-resolving. So the best thing is to just reassure. I should have maybe not put D and E as opposing options. Can we go to the next slide? Okay, we've got another SBA. So that was a chalazion, and now we have a stye. And I've made this a bit of a trickier one because I wanted to test your understanding. A bit more difficult than just differentiating between stye and abrasion. Okay, let's move on. And can we change slide as well? Interesting. So this is a minor point, but I threw it in for the sake of difficulty. A chalazion, which we saw, is a non-infectious cyst, whereas a stye is actually an abscess. I think in colloquial terms, it's basically an infected hair follicle, but because it is a discrete little kind of walled-off collection of infection, it counts as an abscess, but albeit a miniature one. So if we move on, we've got a bit about the management of both of these eyelid swellings. So a chalazion on the left is not so obviously associated with a hair, whereas the stye is. Chalazion, like the key differentiating factor is pain. Chalazion doesn't hurt, it's just like a painless swelling of the eyelid. And in an SBA, it might describe inward folding eyelid. I don't know if that's a sensitive or specific sign, but that's sort of gets mentioned now and again. And as we saw in that SBA, it usually self-resolves. So you can encourage warm compress and what have you to facilitate drainage of the cyst, but you basically just let it sort itself out. A stye is similar. You encourage it to drain itself with hot compress and what have you, but because it is infectious and it is painful, you can give antibiotics for it and incision and drainage. Kind of depends on the patient. But yeah, I think you would get a description in the vignette rather than a picture in terms of identifying the lump. So look for non-painful versus painful is like the really key thing. And in real life, you can see the stye's got some pus inside. You know, it's a bit like a spot or an abscess, what have you. So if we can change slide, Isaac, we'll go on to our last eyelid pathology, SBA. You've just given it away. So it's all right, go back to the answer slide. No, it's all good. So we've gone from eyelid swellings to eyelid like infection and inflammation. So yeah, this is blepharitis, and it's the same thing again. When you've got a problem with the eyelid, like most of the time, you just want to leave it to sort itself out. So this woman has, I don't know if this is actually infectious or just inflammation, but she's got some like crusty, sticky crap around the eyelids with swelling, redness. Again, hot compress and hope it resolves itself. So if we move on, why not bacterial conjunctivitis? It could be. We will see conjunctivitis later, and in fact, they do look very, very similar. So I've got a picture of conjunctivitis, and you're going to say, well, that's just a picture of blepharitis again. We'll move on. We'll come back to it. That picture wasn't great, but the conjunctiva in blepharitis aren't supposed to be involved, so her eyes should be nice and white, but that picture wasn't great. So let's look at eyelid lumps. Chalazion versus stye. It's a non-painful, non-infectious cyst versus a painful infectious abscess. Try and encourage it to drain itself with warm compress and general hygiene measures. If this stye is not resolving or if it's really painful, you can drain it and give antibiotics. Swollen, so rather than a discrete swelling of the eyelid, generalized swelling, we'll call blepharitis. Sticky, crusty, sore eyes, which, as someone has said, looks like conjunctivitis. Management is the same again. Let it sort itself out. I&Ds, incision and drainage. Encourage general hygiene measures and keep your fingers crossed. You kind of, the mainstay or the principles of treatment for eyelid stuff is mainly symptom control, or at least with blepharitis. So if we move on, we'll go to another part of the eye. So we've done the skin around the eye, we've done the eyelids, and now we're on to the conjunctiva. And again, I've made the wordings of some of these deliberately vague. This vignette in particular is a bit crap, but that's what exams at UCL are like. Okay, let's close the poll and see what we've all got. There's a real spread. Okay, so most people have gone, or the most popular option was chloramphenicol eye drops. So people thought this was bacterial conjunctivitis because chloramphenicol is an antibiotic. If we move to the answer slide, I think you were maybe anchored by mentions of bacterial conjunctivitis previously, but this was a bit cheeky. What this describes is this person having several previous episodes of it. It's not a black and white vignette, but I think to have several episodes of bacterial conjunctivitis over time would be unlucky and probably less likely than allergic conjunctivitis, which is kind of related to hay fever and is basically driven seasonally. So I didn't say this happens at the same time every year, but that's kind of what was implied. This person keeps getting conjunctivitis. And so when it's allergic, you can give sodium chromoglycate eye drops and antihistamine eye drops. So we're doing the same thing again. We're differentiating between different causes of very similar overlapping presentations. So it was a tough one, this one, deliberately so. But I just wanted to highlight the kind of the time course that you might expect of each cause of conjunctivitis. So if we can move on, we've got another SBA on this. What is sodium chromoglycate? I don't know. I'll look up how it works while you guys are doing that SBA. A mast cell stabilizer. There you go. Okay. You weren't all getting thrown off this time. Go to the next slide, please. And then you've identified that I've said this is her first such episode, which kind of links to what I was saying. You can see the thick exudate there. That's classic bacterial infection, is that pus. And so, yeah, for this one, you do want to give chloramphenicol. You can let it resolve itself, but this is a child who describes themselves as being in severe pain. Like antibiotic stewardship can be left to the side. You give something to treat this infection just for the sake of the child's comfort. So yeah, chloramphenicol is the first line antibiotic drop in most cases. So then if we go to the next slide, there's another kind of comparison / summary slide. These are two causes of infectious conjunctivitis. So viral on the left, haven't had a question on it, but it's actually way commoner. You can see the conjunctiva in these two pictures look basically the same. They're injected and red. I think the key thing is the discharge and the history. So a viral conjunctivitis will almost always be associated with a viral urti beforehand. So they'll describe coryza, you know, sore throat, blocked nose, fever, headache, all that. And then they'll have kind of watery eyes with red conjunctiva. Bacterial conjunctivitis will be an isolated episode. The discharge is thick, it might be yellow, green, and they can, I think, due to the consistency of it, it can be associated with a gritty feeling or the feeling of a foreign body in the eye. And kind of, as I said, if it was an adult, you could maybe manage conservatively, but it was a child in pain, so give antibiotics. And then, yeah, quick question at the bottom. They each might warrant a period of school exclusion. How much do they each warrant? Bacterial, no. So would you refer if she's in that much pain? Maybe. That's a grey area, depends on the individual. If it makes you feel safe and confident that you're doing a better job, then you can do. But if you were to refer bacterial conjunctivitis to Opthal, they would say, have you completed a course of antibiotics? But 0 days for both. Yeah, it's a trick question. Neither needs to be excluded from school. So let's move on. And then we're going on to the highest yield slide in the entire presentation. This comes up every single year. Just can't share towels and that. Yeah, exactly. So let's see what you all make of this. It's a pretty grim picture. Okay. Aha. Okay, 30%. You're going to learn something really important today. So we can move on to the next slide. I've included this in the conjunctiva section because this is a subconjunctival hemorrhage. It can either be associated with trauma, like knocking yourself in the eye, or you can just wake up and find that it's happened. It looks horrific, but it's completely benign. So the blood will be reabsorbed into whatever drainage system is in there. You don't need to do anything. And I think it comes up in every year 5 and 6 exam potentially. So it doesn't even look like there's inflamed vessels. Like you can't see discrete vasculature. It just looks like there's shed loads of blood in the eye. So easy to recognize and easy to manage. You just do nothing. Do you want me to exclude globe perforation? I don't even know what that is. Can we move on to the next slide? Okay. Conjunctival disease or not disease summary. So conjunctivitis, allergic, is seasonal, might be associated with hay fever and has watery discharge. And then your infectious ones, viral and bacterial. Viral has watery discharge and a preceding upper respiratory tract infection. Bacterial might just happen by itself and you get thick yellow sticky discharge that feels gritty or like there's a foreign body. So that was conjunctivitis. Subconjunctival hemorrhage looks awful, is absolutely fine, do nothing. It will come up in the exam. Let's move on to the next section. Okay. What have we got? There's a bit of a spread again, but interesting. Acanthamoeba. So 26% think that I'm putting a rare infectious disease in. If we can move on, I want to just draw your attention to a classical presentation. Someone wears, it's a bit of a loose association, but it's an important exam one, I think. Someone who has keratitis and wears contact lenses thinks Pseudomonas. The way I kind of remember that in my head is it's very similar to someone who has a peripheral line or a drain or something. If there's ever like plastic in or on the body, for some reason, Pseudomonas loves it. So this isn't dendritic, not really. We've got a dendritic one on the next slide and you'll be able to see the difference. Why is this not a dendritic ulcer? You'll see. So look at that yellow text at the bottom. What's the management of this, of Pseudomonas keratitis? Management of moxiflox. Yeah. Hourly antibiotic drops. Okay, yeah. So moxiflox maybe. I was thinking ciprofloxacin, but same class of drugs. Yeah. So whichever quinolone you give. So well done to you guys at Cipro. Well done to you guys on it, and immediately refer to Opthal. So we will come on to red flag signs and when you do and don't refer keratitis, another presentation to Opthal. You wouldn't necessarily have to do this one. It depends, I think, because they've got acute pain, you could, but we'll clarify that. So if we move on to the next SBA, so topical, yeah, topical drops rather than oral antibiotics. So this is a dendritic. So, I mean, as you guys are asking about dendritic already, I can only assume that you're going to smash this SBA, but a dendritic means tree-like. You can see this looks like it's got roots or branches, whatever you want. It's very clearly different in its shape to the ring-shaped one that we saw previously. So we don't need to spend too long on this poll because I think these guys, or some of them, have cottoned on to what I'm getting at. So, yeah, nearly 100%. Whoever put ciprofloxacin, that was for Pseudomonas. This, if you wouldn't mind, Isaac, is herpes keratitis. The dendritic ulcer is pathognomonic, and you give acyclovir. Is topical treatment again. Okay, let's move on to the final SBA on corneal disease/injury. And this ties into the red flag signs that would make you refer to Opthal or not make you refer. Kind of, I want you to tell what is or isn't here. And I know the fact that I put routine, urgent, and emergency as if there's a clear distinction between any of them is a bit cheeky. Remove the foreign body is getting a lot of votes. So if we move on to the answer slide, you can remove the foreign body yourself. So what nice guidance say is if the foreign body is easily removed, then a GP or an A&E doctor can do it. But there are certain red flag signs, two of which this eye shows. So the person describes themselves being in severe pain, and you can see, I mean, they've said large or deep abrasion. That's quite subjective, like how long is a piece of string, how large is a corneal abrasion. But I think it looks significant. And so, yeah, the guidance says refer immediately if any of these things are present. And corneal opacity, I think it's hard to tell from this picture whether there's any corneal opacity. Isaac, if you wouldn't mind going back to slide 26, SBA 9, I think that shows corneal opacity. Sorry, SBA 8. Oh, no, it was SBA 9. I've been copying and pasting. Yeah. So this one, there's fluorescein over the top, so it's hard to tell, but this cornea looks potentially a bit hazy, so that is a red flag sign. So yeah, you would refer this one to Opthal. So cheers to that, Isaac. If we go back to the key points slide, so slide 32, keratitis, so infection or inflammation of the cornea, presents as acute eye pain, epiphora, that's a nice word that I keep using in this lecture later on, and photophobia. And it's due to either infection or inflammation. If they wear lenses, think Pseudomonas, and give ciprofloxacin or moxifloxacin, as someone said. Dendritic ulcer is pathognomonic of herpes, and a foreign body, you can remove it and maybe give antibiotics if you want, if you're feeling up to it. And I think you get practice on your Opthal week. You get to use a hypodermic needle, and just kind of scrape it off carefully. But you must refer to ophthalmology immediately if any of the red flag signs that are listed there are shown. I can see a few questions coming up. So what is an angle grinder? It's like a piece of machinery that you use to cut metal. And so that guy was doing that, and a little piece of metal flicked off and hit his cornea, and was that pattern was because he was blinking. It was dragging the metal up and down along his cornea. What counts as severe pain? Yeah, I mean, why wasn't he wearing eye protection? You guys are reading too much into this. So 2-week wait counts as urgent. I think urgent is, in this context, like with an eye referral, urgent is same day, so like within hours, and immediate is like whatever the ophthalmologist are doing, can you come and help now? That's what I think is the distinction. Maybe someone can correct me. Anyway, we're getting sidetracked. If we move on from corneal disease to the sclera and the episclera, this is the same thing again. We've got a benign and a less benign presentation or condition, and we're trying to distinguish between the two. So we're trying to identify a red flag. This is again a bit of a cheeky question, but I think because we're quite close to exams now, not that you guys need reminding, it's fair game for me to throw in a few harder ones. So let's see what you've put. Nice. Okay, so the most popular answer was the correct one. So if we can move on, a fixed dilated pupil, that sounds like glaucoma. Photophobia is very non-specific. Small irregular pupil sounds like typical anterior uveitis. If we look at option E, recent flare of RA, I was struggling to think of a fifth option, to be honest. So yeah, no response to phenylephrine drops. And so this woman has an acutely painful red eye and a history of rheumatoid arthritis. So you're thinking it's scleritis. And scleritis and episcleritis, if we can go on to the next slide, they look basically exactly the same. But scleritis is more important, more severe. There's pain on eye movements, and because the sclera is under the episclera, the vessels are a bit deeper, so they don't blanch to under application of phenylephrine drops. How useful that is in clinical practice, you know, whether you see someone and you try and distinguish between the two of the drops, I'm not sure, but it's a bit of an exam topic. So yeah, scleritis is, the sclera, by the way, I think is the white of the eye, kind of adjacent to the, it's the bit that creates the white colour, I think, I'm not really sure. Associated with inflammatory conditions, so rheumatoid arthritis, GPA, and there were some others, but they were associations I hadn't heard of, so I didn't include them. So yeah, pain on eye movement. The pain is the big distinguishing thing between these two. And this is the first red eye emergency that we're going to mention in this lecture. We're going to come on to the others, and we'll come back to the red eye thing in the OSCE section. And so scleritis, you need to treat it seriously. So this person gets oral antibiotic, oral steroids, sorry, and consider that this is a lot of the time on the background of a systemic inflammatory condition. So that's, I think, why you go down the oral route. Episcleritis, not so obvious in these two pictures, but looks the same, but it's not as painful. If you were to apply phenylephrine drops, it would blanch, and rather than going for steroids, you can go for weaker anti-inflammatories, so NSAIDs, because it might just solve itself. So we will move on. We'll leave. So in fact, do you do emergency referral for eye casualty? I would say yes. It's one of the red eye emergencies. So yeah. Here's another cause of acute painful red eye. And loads of options that look the same. Someone said AU. Why not AU in the chat? I'm unsure what that means. Anterior uveitis. Oh, yeah. So typically in an SBA, that would be a small irregular pupil. We're going to come on to anterior uveitis, don't you worry. and then the distinction will be more clear once we've seen both. So let's see the SBA results. Okay, nice. A lot of people got this, so let's move on. Hopefully this will clear up. I'm being sort of pernickety about routes of drug delivery again. If we can move on to the next slide that shows the answer. Oops, whoops. Oh, I haven't. Yeah. Move on to that one. Sorry, the one with the Venn diagram. I'm getting confused. Yeah. So you want to give a topical beta blocker, topical pilocarpine, aproclonidine. I think it's less important, but you can give it. Steroid again, and IV acetazolamide. So you learn like how these drugs work, and I think that is important to know because you could get asked about it. But these three that I've coloured in green, like if you want to learn any drugs, it's this triad of things that you have to give. So topical timolol will reduce aqueous fluid production, because remember the goal of this treatment is to reduce the pressure in the anterior chamber as much as you can by stopping it filling up with fluid and facilitating drainage of the fluid that is in there. So the pilocarpine, sorry about this beeping, pilocarpine will make it, it's a sympathomimetic, will make the pupil constrict, and that opens up the angle the fluid drains from. And IV acetazolamide, I'm not sure exactly what that does. I guess it says there reduces aqueous production. So you can learn the Venn diagram if you want. If not, learn definitely this green triad of drugs. Whether you would need to know the doses in an OSCE, I'm unsure. I would say probably do learn them for an OSCE because it's like emergency drugs and management. But yeah, let's look at the picture. So you can see the right eye in that picture is red, and you can't tell it's fixed because you need to test it, but you can see it's definitely dilated. And so fixed, dilated means it's larger than the left, and if you shine a light, it's not going to constrict as it should. So let's move on to the next SBA. So we've gone from acute angle closure glaucoma to chronic open angle glaucoma. These are the two types of glaucoma that you need to know. So yeah, this again is a specific question, but it links to the principles of management. Okay, let's close the poll. Before I move on to this next slide, so the correct answer is the most popular one, the bottom one. Can someone put, yeah, in fact, someone's asked what is tonometry, so someone put in the chat what that is. If I put it in layman's terms, it might have been more obvious. If I'm getting all these wrong, should I drop out? No, you should stick with it. Measuring eye pressures, yeah, it's a measurement of intraocular pressure. So if we move on to the next slide, I've got a little summary slide later on actually on glaucoma. We've got another SBA after this. Isaac, if we can go to the next slide after this. Yeah, so ocular tonometry, sorry, not this one, the answer slide. Ocular tonometry, so measure the pressure in the eye and visual field assessment. So people don't know the complete ins and outs of the mechanism of this disease, but it's thought that high pressure in the eye contributes to destruction of the retina and loss of the visual field. So monitor the pressure and monitor the visual field. And I'm not sure the frequency of monitoring, whether it's yearly or what have you, but if the pressure is too high or the visual field loss is too rapid, I think the mainstay of what you try and do with regarding to treatment is reduce the pressure. We'll come back to the summary slide on glaucoma. We've got another SBA, and then yeah. How many opthal questions in the SBA? To be honest, not as many as we've got in this session. It's a weird one. I thought opthal in year 5 was tough, and then went over it again in year 6, and I thought it was dead easy. It's because what I'm trying to go through with you guys is like all these overlapping and sort of hard to pick apart presentations and managements and stuff. It's weird. You get over the opthal hill and it becomes easier. But yeah, it is definitely like very bitty and tough to get your head around at the start. But yeah, let's do this SBA. Okay, let's close the poll, see what we've got. So this is the second, in fact, not the second, the third red eye emergency of the session. So we talked about scleritis, and then we looked at acute glaucoma. The third one to remember is anterior uveitis. So if we move on to the answer slide, it's got a lovely picture. The typical description is small, irregular pupil. I think that it's because you get things called posterior synechii, which is, it's almost like intra-abdominal adhesions. It's like parts of the eye sticking to each other. This picture doesn't show it great, but if you Google anterior uveitis, you do see irregular looking weird pupils. So it's an inflammatory process. So you give a topical steroid, hydrocortisone, and atropine works as an analgesic by paralyzing the ciliary muscle, which is in spasm, and kind of relaxing it and relieving pain that way. And hypopion, that means white cells in the anterior chamber. That's that weird little fluid level that you can see there. It's kind of like the pus that we saw in the stye earlier. Like whenever the immune system fights against bacteria or gets overactive, you get this exudate as like the casualties of war, and so that's what that looks like in there. Yeah. So if we move on to the next slide, we've got the key points of glaucoma. If you don't mind, thank you. Yeah, so acute glaucoma is an emergency. Red, painful eye, like pain bores into the head. Epiphoria, remember that's like lots of tearing. A fixed dilated pupil is a typical, like if you see fixed dilated pupil, it's acute glaucoma. And so the two investigations, gonioscopy. Gonioscopy is a weird one. You put a prism up to the patient's eye and it reflects light and it lets you see inside the anterior chamber, and you can look at the angle between the iris and the cornea. And in acute glaucoma, you have a closed off angle, which reduces drainage of aqueous fluid from the anterior chamber. So you can look at the angle. You can also measure the pressure in the eye with tonometry. If you get to watch it, it's pretty cool. It's kind of funny. You put this little gun up to the eye and it fires a teeny plastic ball, and I think it measures something about the rebound of the little ball off the eye, and I think a high pressure eye bounces the ball back more, and so it gives you a higher pressure reading. So yeah, management is in two stages. The emergency management, which is what we went over, so you give topical beta blocker, topical pilocarpine, and IV acetazolamide. That's a triad, and you can give others, but these are the three to really definitely learn. And then after that, I've mentioned there follow-up treatment or prophylaxis. So secondary prophylaxis of the affected eye and primary prophylaxis of the other eye. You can do peripheral iridotomy, which is where you put a hole in the iris, or iridectomy, where you put a hole in by taking a chunk out. In either case, you want to facilitate drainage of fluid from the anterior chamber by creating a new passage for it to move through. So that's glaucoma in the acute setting. In the chronic setting, the treatment is it's less definitive. It's more like damage reduction. Anyway, we'll go through. The presentation is visual loss peripherally that progresses to central loss, which is why in the monitoring that we talked about, you have visual field assessment. If you want to diagnose it, first off, you can do fundoscopy and you'll see swollen discs, also known as papilledema. You do visual field assessment and pressure reading again, because chronic glaucoma also has high pressure in the eye, and treatment revolves around trying to reduce that pressure. So topical timolol, as in the emergency management, and latanoprost is a drug that comes into the management of chronic glaucoma that's not seen in the acute management. I'm not sure why that is. That's a prostaglandin analog that I can't even remember the mechanisms of these different drugs. Let me see what I've got on my slide. How does latanoprost work on this Venn diagram? So it increases aqueous outflow. If you don't want to learn that, because it's a bit dry and not very intuitive and easy to remember, then whatever. If you do want to learn it, then great. Anyway, we'll move on. We've got another question. In fact, we've got another key point slide. So the first anterior chamber pathology was glaucoma, i.e. high pressure. The second one is anterior uveitis, i.e. infection or inflammation. So acutely painful red, small, irregular eye with hypopion, and it's usually going to occur on the back of something else. So IBD is a really typical one, and you guys will have learnt that in 4th year, and Angstbond as well. You learn in 4th year, you learn what anterior uveitis occurs without really learning kind of what it looks like. So now we're putting the pieces together, which is one of the nice things about 5th year. But yeah, there's loads of things associated with it. I think learn the bold ones more so. These are the ones that I read and I was like, oh yeah, definitely heard of that. So reactive arthritis, there's the aid memoir, can't see, can't pee, can't climb a tree. So can't see is uveitis, can't pee is urethritis, and can't climb a tree is arthritis. That's like the triad of reactive arthritis after kind of a UTI or a GI infection, but maybe more of a year 4 and 6 topic, but we're just linking back. So the treatment for anterior uveitis, reduce the inflammation with a topical steroid, and sorry, a systemic one, and reduce pain and ciliary spasm by giving atropine. Let's move on. We've only got what I've not put an SBA on cataracts because I think once you get what cataracts are, it's straightforward. So it's opacification of the lens. This bold stuff is what you really need to learn. So if someone smokes or drinks a lot or has diabetes or takes steroids, then they can get cataracts. And it presents as progressively blurred vision, so they might find it harder to read signs when they're driving or read the paper, whatever. And they'll get halos around bright lights and blurring. And it's easily managed. I think in about 15 minutes you can do the surgery where you take out the lens and put an artificial one in. Can anyone, latanoprost causes brown hyperpigmentation of the iris? Yes, that's one of these exam things. People learn that. It's like it's completely useless knowledge. And I didn't put it in the slide for that reason, but yeah, that prostaglandin drop makes your iris go brown. But anyway, cataract, what is the name of the surgery that you would probably go for in treating a cataract? Does anyone know? It's got a funny name. Cataract surgery. Is it phacoemulsification? Yeah, so I don't think it's the only option, but phacoemulsification, you put this tiny little ultrasound probe in that works at a frequency that can destroy the lens, and you kind of like chop it apart and blast it up with ultrasound, and then you fit the new lens in. It's pretty cool surgery, just it's really sort of tiny and neat. But anyway, we'll move on from the lens to the posterior chamber / retina. I haven't got SBAs, so this is again like you really want to be able to distinguish between two similar things that cause the same presentation. So what we've seen in visual loss previously, that with acute visual loss, was it was painful. So that was like anterior uveitis, glaucoma, scleritis. They had visual loss, painful. This is acute visual loss that's painless. And it can either be occlusion of the vein or the artery. The vein I've put on the left because it's more common. And you imagine you have a backlog of blood on the retina and it bursts vessels, which kind of can't take the pressure. And in a vignette, it'll be a stormy sunset on fundoscopy, or you'll get flame hemorrhages. On the right, blood can't get into the eye, and so it goes all pale. And you have a cherry red spot there. So pale retina, cherry red spot. These are like the buzzwords that you might get. I think we potentially had CRVO in the year 5 or year 6 exam, and you don't have to know how to manage it or anything. You just get shown a picture, or you see a description and they're like, what is this diagnosis? So yeah, just kind of pictures to recognize and buzzwords to recognize. So if we move on, there's 2 more causes of painless sudden visual loss relating to the retina. So that was vasculature blockage. This is detachment of things, and distinguishing between vitreous detachment and retinal detachment took me so long to get my head around. I'm not convinced that I do have my head around it. So they're both sudden visual loss. You can get flashes and floaters. So flash is called, you might see photopsia, I think. Vitreous detachment leads to retinal detachment, and vitreous detachment itself is preceded by neovascularization. So I think in someone who has like chronic diabetic retinopathy, which is on the next slide, you have new vessels grow into the retina, and I think they can literally push the vitreous away, causing this picture that you see here, and then that itself can pull the retina away, which you see on the right. I think it's tough to distinguish between the two. What you might get in retinal detachment is a description of a curtain falling down or a dark cloud or something coming over part of the vision. That's kind of similar to amaurosis fugax, which is like a TIA of the eye where a dark cloud comes over, but that'll resolve itself, whereas this doesn't. So if you're looking on fundoscopy, you can see on the picture of the left here, you can kind of see the back of the eye, but it's really blurry, and that's because the vitreous has come forward and it is obscuring your view of it. The picture on the right, you have got a clear view of the retina, but you can only see the bottom part because the top part has fallen down and is kind of like obscuring part of the vision. So they both present painless, sudden visual loss with flashes and floaters. Vitreous is commoner, I think, and leads to retinal detachment. And if you have fundoscopy, you can kind of tell the difference. If we move on, we've got more retinal disease. So this isn't sudden onset, acute, painless visual loss. This is metabolic retinal disease. So on the left, if you go on PassMed, there's like the grading of diabetic retinopathy in terms of what you see and how many quadrants they present in and that. Don't worry about that. I would be shocked if you got a question on it, but you want to recognize, again, pictures and buzzwords. So you can have hemorrhages, which is a blot, and they can hemorrhage from microaneurysms or dots. You can get a cotton wool spot, which is an area of ischemia. You can get hard exudates. I'm not sure where the exudate comes from, but it looks like a patch of yellowy, dotty crap in the eye. And you can get neovascularization. And diabetic retinopathy is treated with optimization of the diabetic controls to try and keep your blood sugar down. You can give laser therapy or retinal photocoagulation, and you do that for two reasons. Firstly, if there's neovascularization, so the disease is so severe that the ischemia at the back of the eye has driven growth of new vessels, or if it affects the macula itself. So the macula is kind of like the center of the eye. If you look at picture D of the figure on the left, the bit labeled hard exudates, I would say that's the macula. It's like the center of the eye. It's where you have the highest focus of, I can't remember rods and cones now. I think rods are the ones that give you color vision, right? Maybe someone will correct me, but macular disease is the second indication for laser therapy. On the right, hypertensive retinal, cones of color, cheers, okay. So cones, you have a high density of cones at the macula there. So if you get disease there, you're in a spot of bother. Anyway, hypertensive retinopathy, you can't treat with laser therapy, you just have to try and control the hypertension. And some of the presenting things are the same, some aren't. So you can get blots again, you can get blots and spots and exudate, which is the same as diabetes. What you might get in an SBA is AV nicking, which is where an artery and a vein are kind of growing over each other. And I think the artery, the pressure in it can occlude the vein and stop its drainage. Something. I'm not really sure what the nicking part means. Or you can get copper wiring or silver wiring, where you can see kind of a light silvery line over the center of the vessel that you wouldn't see otherwise. And note, it points out disc edema as well. Maybe that's because this person's got hypertension causing the disc to bulge at the back. But yeah, you wouldn't necessarily know how to manage it because it's like case by case basis, but just try and control the high blood pressure to try and stop the progression of this hypertensive retinopathy. Okay, so that's those two. Again, like tricky, they present the same, they look similar, but they're not the same. It's just opthal being a bit naughty. If we move on, oh, AV nip, yeah, so I thought it was nipping as well. I've just said nicking because it's in the diagram. Whatever. Let's move on to the next slide. We've got even more causes of retinal disease and visual loss to think about. So macular degeneration, we've got a picture on the next slide of what the two types look like, but this is what they describe. So glaucoma, we said, was a chronic visual loss and that started at the periphery and moves in. This you can see is central visual loss, and they get blurring, distortion of straight lines, and so the person might describe difficulty reading the paper or seeing faces. They can have difficulty discerning between different colours. So you can see the picture on the right is slightly desaturated compared to the one on the left. and they have difficulty readjusting to dim light. So if you go outside in summer and come back into the house, it might take you longer to readjust to the dark environment. So yeah, this is what someone with macular degeneration will see. It doesn't matter if it's wet or dry. If we go on to the next slide, we'll try to distinguish between the two causes again. Okay, so dry on the left. Characteristic thing that will differentiate dry from wet is drusen or dryzen, if you want to remember it that way. So they're fatty, proteiny deposits at the back of the eye. They look kind of similar to the exudates that we saw in the other retinopathies, just to create further confusion for you. But yeah, they're that. So they'll have central visual loss, and on fundoscopy, they'll have these little deposits at the back of the eye. And there's nothing you can really do about that. People have tried antioxidant vitamins and stuff. I don't think anything's proven to work. But dry is not as bad as wet. So if we look at wet on the right, you don't have drusen, i.e. the speckly yellow crap all over, but you can see the macula there really clearly demarcated. It's wet macular degeneration because it's edematous, or there's wetness at the back, if you want to think of it that way. And you can treat this intravitreal anti-VEGF. So you inject monoclonal antibody into the back of the eye to stop, I don't know the exact mechanism, stop new vessel growth or what have you, but yeah, anti-VEGF is the treatment to know. I included the names of the monoclonal antibodies. You do not need to learn them, but I thought it was funny. If we look at the one that's highlighted yellow, I thought someone must have been taking the piss when they named that, because if you read it in a London accent, it's like, bro, look, is you mad? Maybe they're having fun with it. I don't know. Maybe I've seen something that's not there. But yeah, that's macular degeneration. Let's move on. So again, this is another like shitty SBA that I've made, but it kind of links to the principles of the management of this condition. So anyone who can recognize this and recognize that you give an anti-inflammatory but doesn't know which kind is going to think this is a bit of a shitter. And if you can hear that voice, that's Moss downstairs losing it watching the Euros, I think. We've not got much left of this session. We're going to do OSCE stuff and then spot diagnoses, and then I'll let you go watch the football. I'm not sure who's playing. Let's see what we've got. There's a spread, okay, but most people are getting it. So if we move on to the answer slide, this is optic neuritis. Oops. I put that she's from Sweden, not just for the sake of racism, but because Sweden is a country of high latitude, i.e. is far away from the equator. These people have a higher prevalence of optic neuritis and multiple sclerosis and what have you. It's thought that vitamin D can somehow lead into the mechanism of this disease development. But yeah, she's got the triad, like someone from high latitude presents with reduced vision, loss of colour vision, and pain on eye movements. And that is the triad of optic neuritis, and it's worth learning. And so IV methylpred, because this is, I think it's an emergency, you want to give a strong, quick-acting steroid, and so that was the best option here. And then if you look at this blue box, I've included some info about Devick's disease. Some of you will know this, some of you won't, but I think it's come up in previous SBAs. It's a type of optic neuritis, but the patient presents with another triad, which you can go and learn if you want. The key thing that gives it away is anti-aquaporin 4. I think that's what was in the previous question. I think Adam Ali goes on about this as well, because it's a bit of a nerdy topic. Aquaporin 4, we remember, is in the nephron. So why these people present with anti-nephron receptor antibodies and optic neuritis and I don't know, it's a bizarre disease, but and the likelihood of it coming up again, I'm not sure, but it has come up previously. So anti-aquaporin 4 and optic neuritis, think Devick's, and it kind of overlaps with optic neuritis and multiple sclerosis and what have you. And in astrocytes of the brain, there you go. Whoever knows that is hot shit. Let's move on to the next slide. We've got no more kind of SBA stuff because some of you said, let's do OSCE things. It's difficult in an online lecture to give like worthwhile OSCE practice. But as I said earlier, I looked on the amnesty. The thing that seems to come up again and again for ophthal is a history of acute red eye. So while I can't simulate a station with you guys, we're going to go through the causes of red eyes, the things to ask about, things to look for, and I'll hopefully give you a bit of a mental framework to use for when you are practicing this and when you do the station. So let's go on to, oh, in fact, no, don't move on to the next slide. People put in the chat, what are the 3 key emergencies that we want to rule out? So we've talked about these in the session already. 3, acute angle closure glaucoma, scleritis, and anterior uveitis. So yeah, these are the 3. If we move on to the next slide. So keratitis, I think, is important, might not have a red eye and is not a typical like red eye presentation. I've included endophthalmitis there just for the sake of it. That's an infection inside the eye. Not as important, which is why the font is slightly smaller. So yeah, these are the 3 things that we need to rule out: glaucoma, uveitis, scleritis. So we move on to the next slide. There are 6, you want to take a full history, but there are 6 things that are specific to this presentation that you really have to ask about. So what are the 6 questions that you need to ask? So these are trying to discern between causes and trying to eliminate red flag symptoms. So pain, that's your first one, yeah. Visual change, photophobia. So these are, yeah, these are the first 3 that I've got on my list. Discharge, yeah, systemic symptoms, ocular history. So you guys, I think, have referred to the same resource that I referred to. I've kind of nicked this off an ophthal lecture that I found on Moodle because I want it to be useful. But yeah, if we move on to the next slide, these are things to ask about. So if we can move on, Isaac. So any change to vision, if you think about benign causes of red eye, so like conjunctivitis, episcleritis, subconjunctival hemorrhage, there's going to be no change to vision. Whereas in the emergency ones, glaucoma, scleritis, uveitis, there might be reduced vision. So pain, these 3 that we've talked about are painful, and that might be severe pain, boring into the head. It might be pain on eye movements. Photophobia is another one. Discharge. So remember, we talked about infectious causes. So you might have thick discharge, watery discharge. Any history of eye disease. So it's a bit harsh to call myopia or short-sightedness eye disease, but that's an important, like that will mean the person wears glasses. It's an important thing. A short-sightedness can lead to glaucoma, which is one of the emergencies we're thinking of. And then any systemic symptoms. So that might be, have they got joint pain? You know, are they a rheumatoid patient with scleritis? Have they got urethritis? You know, have they got like reactive arthritis causing anterior uveitis? But yeah, we'll break down each question at a time. So we move on to the next slide. The first question, any change to vision? So is that visual loss central or peripheral? How quickly is it developed? Is there blurring? Is there loss of color vision? So I haven't put much more info on these slides, but central visual loss, we're thinking like maybe glaucoma, maybe other things. We'll move on. So these slides are a bit vague. Is the pain in the eye? Is the pain around the eye? Is the pain on moving the eye? If we move on, I've forgotten to fill in this slide because I've been trying to move to the next slide. Slide 58. Yeah, this one's blank, but photophobia, because I wasn't really sure what to ask. Different types of photophobia, I don't know, but ask about photophobia. Next one, discharge. So you want to find out colour and consistency, if there is any. History of eye disease, if we move on. Are they myopic? Have they had any episodes previously? Have they had recent eye surgery? So that relates to the endophthalmitis that I was on about. Like if they've had the eye instrumented recently, they're more prone to an infection. If we move on, systemic symptoms. So arthritis, urethritis, skin changes, flare-up of diarrhea or constipation. Yeah, okay. I've tried to link it back to the 3 emergency presentations. So if we go to the next slide, acute glaucoma, what might the answer to each question be? We'll go to the next slide. Yeah, so any changes to the vision. So glaucoma, yeah, they would. They'd have acute reduction and the vision would be blurred as well. They'd have pain in the eye itself. They wouldn't necessarily have photophobia. They would have so discharge, they would have a lot of tearing. Not sure if that's the same as discharge itself, but the patient might describe like really watery eyes. They'll say they're short-sighted, any systemic symptoms, so they'll feel sick and they'll have a headache. So this is like typical acute glaucoma. Oh, maybe it's long-sighted. Oh, I don't know. Let's think. Yeah, maybe it is long-sighted. A short, compact eyeball will have a narrower angle, make you long-sighted. Anyway, you can tell I haven't done opthal for a bit. If we move on to the next one, what might the answers to these questions be in anterior uveitis? So they'll have blurry vision. The pain will be in the eye itself. They will have photophobia, which they wouldn't have in glaucoma. Again, watery eyes. They wouldn't necessarily have a history of eye disease, but they might have a history of other inflammatory diseases. So diarrhea if it's IBD, back pain if it's angst causing this. And then scleritis. If we move on, the third red eye emergency. Change to vision, yes, it'll be blurry. The pain will be in the eye and on eye movement as well. So that was something that we might not see in the other 2. They will have photophobia, they will be watering. They won't have a history of eye disease, but they might have a history again of inflammatory disease like rheumatoid and joint pain. So we've talked about the kind of the emergency red eyes. The next slide lists some other more benign differentials to have in mind. So subconjunctival hemorrhage we saw again. They'll put that in an SBA, not into the OSCE station. Conjunctivitis will be painful and it'll be red, but they won't have any visual loss. They won't be systemically that unwell. They might have discharge. And then episcleritis looks like scleritis, but kind of it's fine. If we move on to the next slide, so I'm going to make this a bit more interactive. Let's pick 3 key examinations of the eye. So I saw someone joking about don't take history, just look at the eye. That's kind of true. PR exam, if the patient wants that, then maybe. Fundoscope, yeah. So you can do fundoscopy. Slit lamp, yeah. What do you mean in real life or in an OSCE? End of the bed exam, visual field test. Okay, so if we move on. So these, you can do a whole sort, but what I thought like the A&E doctor would do rather than the opthal doctor, you can do acuity. Anyone can do acuity. So is their vision blurry? You can do visual fields. So you can do that formally with the machine that does it, or you can just do the way where you waggle your fingers as we're taught in OSCEs, and you can do a slit lamp exam where you look, you can look at the eye, look in the eye. And what investigations would you perform? Ishihara plates. So yeah, you could do if you thought it was optic neuritis and there'd be loss of colour vision. Urine dip the tears. What investigations? BP. Yeah, you can do BP if you think you've got glaucoma. Tonometry. Yeah, I put tonometry. OCT. So OCT, ocular coherence tomography, ocular coherence, that's like doing a CT scan or something, or a scan of the back of the eye. That's for monitoring macular edema. Not so useful in the emergency setting. Lumbar puncture, you're going too much down the idiopathic intracranial hypertension route, I think. Visual field assessment, so yeah, you can do it formally rather than as a quick screening exam. Gonioscopy, yeah. So if we move on to the next slide, this is what I got. Gonioscopy and tonometry for glaucoma. Isaac. Yeah, gonioscopy and tonometry, they're your glaucoma ones. Fundoscopy, have a look at the back of the eye, and you can swab if there's discharge, but that's less important. Okay. We've got 2 more slides on OSCE stuff before I'm going to stop talking shit and we'll do the spot diagnoses. So, yeah, okay. So the key management. So in the chat, what do you do if you see any red flag symptoms? Help. Yeah, get help from Opthal immediately. Dr. A to E, yeah. Okay, so any red flags, you want to get help from Opthal. Like the threshold for getting Opthal involvement is so low. Acute glaucoma, what was the triad of drugs that I told you about? Acetazolamide, yeah, IV. So TAP, yeah, I like that. TAP, so timolol, atropine / pilocarpine, or acetazolamide and pilocarpine. So yeah, TAP. I've never seen that. Scleritis, what would you give? Steroids, yeah. Anterior uveitis, what would you give? Steroids and a cycloplegic, exactly. So that was to reduce inflammation, reduce the pain. Then endophthalmitis, this is less high yield, but I threw it in. What would you do for that? Antibiotics. What route of delivery? Intravitreal, yeah, exactly. So Isaac, if you can stop watching the football and move on to the next slide. Exactly, so this is what you guys said, call Opthal immediately. Okay. I don't know how useful this session's been. I haven't trialed it. I just kind of like brainstormed it today. We've never done an Opthal OSCE, so I haven't practiced it myself. So I tried to make what I thought would be useful prep on the red eye station. If it's been shit, you can tell me in the feedback. That's fine. Otherwise, we'll move on to the spot diagnoses section, the fun DOS bit. Time for spot diagnoses. Okay, so it's going to be a race. So this person's got tremor and hyperreflexia, Graves' disease. Yeah, that was fast. So yeah, if we move on, Isaac, please. This is Graves' or thyroid eye disease. So what you can see here is proptosis and exophthalmos. Basically, the eyes are bulging out. It's not normal to be able to see the whites of the eyes above the iris there. So that's a bit of a telltale sign. This is the biggest stock photo since Cushing's lady. Yeah, that's so fair. This was the first picture on Google Images. If we move on. So what's the difference between proptosis and exophthalmos? I think proptosis is like, I'm not actually sure. I think it's forward movement of the eye, whereas exophthalmos is like the eyes are literally coming out of the head. Oh, proptosis can describe any organ that is displaced forward, while exophthalmos refers only to the eyes. There you go. Okay. Central retinal artery occlusion, bullseye maculopathy. Okay. Yeah, so move on to the next slide, please, Isaac. This is, I didn't call it maculopathy, I called it retinopathy, but same thing. So hydroxychloroquine, which is a drug that you give for rheumatoid and other inflammatory conditions. It's a DMARD. It can cause this bullseye retinopathy, so visual loss, and on fundoscopy you'll see this. Ed doesn't have hands. No, I don't. Does Ed not have a mouse either? No. I'm having to control my computer with my mind. If we move on to the, oh, but I'm having to get Isaac to control because when I take control, it messes up the display for me and I can't see what I'm presenting. I thought hydroxychloroquine is for COVID. Let's go on to the next slide. It's a young patient, so we're thinking it's a year 5 topic. Shaken baby syndrome. Kawasaki, yeah. So if we move on to the answer slide, please, Isaac. She's got cervical lymphadenopathy, peripheral edema, strawberry tongue, swollen, cracked lips, and bilateral conjunctivitis that's not infected. Nice one. I've been demoted to slide lackey. Yeah, I'm really sorry. I like to do this myself, but in fact, let me take control, see what happens. Oh, okay. That works. Can you guys all see this new slide? I can't see the main slide, but I can see it on my little navigation tool. I've got it up. Idiopathic intracranial hypertension, someone's already sent in. Yeah, so this person has headaches and papilledema. So papilledema, by definition, is bilateral swelling of the optic discs. So yeah, if you have a unilateral optic disc swelling, apparently it's not papilledema. Anyway. In fact, Isaac, can you please take over again? I can't see. I'm not just taking liberties. I can't see. Thanks. Okay, what's this? GCA. Yeah, exactly. So I've included this because if there's any visual loss, you need to give IV methylprednisolone immediately because they can lose their sight. Let's move on. Bald head equals pred. Name of the sign and the diagnosis. So someone said retinoblastoma before the slide even came up. So I don't know how you guys are getting that. But yeah, this is retinoblastoma. So if we can move on, what's the sign? The sign's leukocoria, so loss of the red reflex because a little tumor inside the eye is obscuring the passage of light to the retina and back. So the eye looks white rather than red. How can you tell if cataract or retinoblastoma? No, you can't. To be fair, you can get congenital cataracts. Although whether those would be bilateral, I'm not sure. But yeah, I was getting at retinoblastoma. Let's move on to the next one. We've talked about this one. Endophthalmitis. Yeah, we don't see any more. So move on to the next one. Pterygon. I'm going to be anal and not give you it because you haven't spelt it right. Pterygium. Yeah. No one spelled it right. It's pterygium. No. Stop sending in typos. Pterygium. Yeah, there we go. Someone got it. If we move on, please, Isaac. This is some weird growth of the conjunctiva. You don't need to know how to treat this. I don't think you have to do anything. If it grows over the pupil like it has done there, I think it can threaten sight, and then you do have to do something. Yeah, let's move on. The next picture is grim. Herpes zoster, yeah. Herpes zoster ophthalmicus. So this is zoster infection of the ophthalmic branch of the trigeminal nerve. What is the name of the sign? Hutchinson sign, yeah. So Hutchinson sign is involvement of the tip of the nose, and that suggests that, I think that indicates that there's going to be like ophthalmic involvement. But you can see this guy's gone way past that, and he's got like, I don't know why, the eye is just destroyed. So remember, this branch of the trigeminal gives sensation to the cornea as well. The infection has actually spread to the cornea, and this guy's got ulceration. This is well grim. Yeah, let's move on. If we can go to the answer one. The next slide, please, Isaac. Yeah, tip of the nose, Hutchinson sign, blah, blah, blah. Grim picture. Okay, we've got three here. Three iris ones. Wilson's, someone said. Kaiser Fleischer and Wilson's, yeah, that's the left one. That's copper deposits around the iris. Corneal arcus in the middle, yeah, so that's fatty deposits. And heterochromia, yeah, so if we move to the answer slide, please. Far left, we've seen is the disease, Wilson's disease. Middle is hyperlipidemia. The one on the right is not disease. It's genetic mosaicism. For some reason, I don't know if anyone else has seen this. Huskies and dogs like that tend to have a really high prevalence of this, of eyes that are different colours. Funky eyes. Cool. Let's move on. We've got 4 pictures left, including this one. So this relates to something we were talking about. Laser treatment, yeah. So if someone, as we said, has neovascularization or macular disease in diabetic retinopathy, you can do pan-retinal photocoagulation. So this looks horrendous. I think we potentially had an SBA on this as well. It's like what they get you to just diagnose what's happened there. So if you move on to the answer, please, Isaac. This is laser treatment, yeah, laser treatment of the eye. Some of you are going to like this next picture. If we go on to the next one, Those of you who acanthamoeba keratitis, yeah. So this is the tropical disease version of keratitis, which we looked at. So I didn't put it in earlier because you're unlikely to get it in the UK. If you go to, I think I read it's in certain parts of Africa and certain parts of Asia. If you get contaminated water in your eye and keep it trapped in there by contact lenses, you can get this amoebic infection and destruction of the cornea, and you can go blind from it. And America, COVID causes it as well, essentially. So someone's sending in the answers before I move on to this slide, which is a bit unsporting. But if we move on to the next one, the next picture, I mean, is this a swimming one? Yeah, so that's what I was getting at. So this is very similar to something that we saw earlier. Central retinal vein occlusion, no. Nearly, yeah, branch retinal vein. So if this was central retinal vein occlusion, those flame hemorrhages that you can see at the top, you would see at the bottom as well. But this is actually just one branch. And so it's the same thing, but it only affects half of the eye. Bolin, are you single? Yeah, I always have been and I always will be. Can we move on to the next slide? This next one, none of you are going to, in fact, I'll be shocked if anyone knows what the next picture is. This is crazy surgery that someone once told me about. If anyone knows the name of this, I'm going to be so impressed. Basically, this is not a cadaver. This person had chemical burns to the face. You can see they lost their right eye. The left side, the cornea, was destroyed. And so part of their body was used to give them this replacement cornea. Does anyone know? So that weird eye that they have there on the left, that's part of their body that's been moved across. Can anyone guess what part of the body was used? Nostril. No. So the nose was damaged in the burn as well. They haven't taken part of the nose. Thigh, some cartilage. You're close with cartilage. Ear. No, not ear. Bone. Yeah, so bone is getting really close to the correct answer. Tooth. Yeah. I don't know whether you looked at the next. Jonathan, cartilage had nothing to do with this. If we move on to the next slide, what this person had, the tooth was taken out, was cut into this shape that it's in here, inserted into the cheek for a bit so that the oral mucosa grew over it, and then they put it into the eye and fit this lens in. And obviously it looks grim, but it allows this person to see, so it's pretty revolutionary treatment. Yeah, it's called osteoodontokeratoprosthesis, or tooth in eye surgery. It's pretty mad. It was first pioneered in the 60s or 70s in Italy, I think. I was reading about it on Wikipedia earlier. But yeah, that's it, I'm afraid. I saved the best till last, I thought. Does our year have better banter than the year below? Yeah, they don't really banter. They're all well behaved and just sort of, they sit there and quietly learn, whereas you guys fill the chat with absolute shit. We're done. If we move on to the next slide, we've got a little thank you. I don't know if anyone's made a feedback form. If they could send that in now, that'd be great. Otherwise, I don't know if the football's still on, whatever Moss was watching earlier. If it is and you're into that, go and enjoy. But yeah, cheers for coming. Hope you've enjoyed it. I hope that OSCE section was all right.
Ed, I don't have a feedback form for you. Would you like me to make you one now?
All right, I suspect we're going to lose most people before I've done it anyway, but I'll, if anyone wouldn't mind sticking around.
Send it into the group as well. Do you want me to make one now?
It's all right, I'm already doing it. But yeah, cheers for steering for me. The screen, I don't know why it happened. The screen went completely.
Do you guys think Ophthalmology SBA last year was doable? That's reasonable. Yeah, they were all like the cataract thing. What surgery is it? There was one about conjunctival hemorrhage.
There always is, yeah. Okay. I've just captioned the feedback form. If you wouldn't mind, like you guys get the drill now. I feel like we've asked you this so many times.
Right, Ed, I'm gonna dip.
Okay. Yeah, no, cheers for helping.
No problem.
Sorry that I had to make you
No, it's all right.
I'd laugh at you.
It's fine. Am I tomorrow, aren't I? Yeah, Friday. Cool.
We would maybe do a role reverse if it's still not working.
I'm sure it seems to work for me. Anyway, I need to dip. I'll catch you in a bit.
All right, cool. Thanks for coming. Right. Let's see if we can answer